but that's kind of the goal of what we're doing here with this community cafe. So I'm going to try to move this thing. There we go. Okay, great. For those of you, some of you I met on Monday, some of you are here, some of you I met last week. We've had a lot of introductions to UIC, but for those who are new, welcome to Chicago and welcome to UIC and welcome to our community cafe. So the community cafe and EOHS was something we launched actually just last spring in collaboration with the training programs here. And it's really focused on community building with these goals: sharing interdisciplinary research, thinking about professional development opportunities. So we all need professional development. We all need networks of people. Part of growing and part of building a career in environmental and occupational health sciences is creating new partnerships and new collaborations. And in order for that to happen, we have to know what everybody else is doing. So we really wanted to have this place and space to share information. And last spring, we have a number of recorded talks from faculty in the division. And hopefully this spring fall, we're focusing on that as well. And we also want this to be a really welcoming, respectful space for sharing of new ideas. So, and we want engagement as part of this. But so we have, let's see, Badisha, where are you? She has been helping. Badisha Gang, many of you who are part of the NIOSH research training program. This is really, I'm going to put these down. Training program. No Badisha, but she is has really been helping to put together this great schedule for us. So today is the kickoff. It's me sort of explaining what we're doing here and why we're here. Next week, we'll have David Jacobs, who has been a long-term faculty member, but also an incredible researcher. He does healthy housing and lead work, and he does a lot of applied research. We'll go on. Oh, actually, Laurel's first, Laurel Berman. So our first two speakers, I'm not going to go through the whole list, but our first two speakers are folks who are affiliated with our division, who do a lot of applied research in land use redevelopment, housing and urban development and design. And then we have our very own Dr. Kim Hargis, who does occupational medicine here at UIC, who's coming to speak to us. And then we have some students who've been funded on pilot grants who are coming. So we have a mix of things that are happening, and we're working on moving this forward. So I'm excited about speakers this fall. We're going to be thinking about how this works, and we're always in the business of process improvement. So if you have ideas or thoughts for speakers or sessions or things that you want in the spring, please let us know. Probably, maybe we'll send out some Qualtrics forms or Badisha, or there's little pieces of paper at the end of your table. So if you have ideas for speakers, feel free to put it on a post-it and leave it with one of us. Okay, questions about any of that? Okay, great. So today I thought we would, I'm not going to talk forever because really I thought I could introduce myself a little bit, not to be selfish, but mostly because I haven't done a community cafe yet. So I thought some of you who are here might want to know what I do in my free time a little bit. Okay. Thanks. Can you turn the light? Oh. Okay, is it working? I can't hear. I can't hear the sound of my voice drives me nuts. Okay, and then so we'll talk a little bit about the division, all of the different components and parts. And I know we have a lot of the leaders here in the room who are part of different programs and centers. And then time for social engagement. Once we learn about what everybody's doing, that's really what I hope to do today. So, okay. I am the division director. This is formal, but more informally, I like to be out and about doing fun things. I grew up as a swimmer, so I tend to not dry my hair, which is a weird thing, but something weird about me is like, I really like to get up and just leave my hair but I also know that sometimes I have to be a professional and dry my hair. So I have multiple looks. You'll see it throughout the semester. So for students, I have office hours on Wednesdays from 2 to 3. This semester, I'm teaching EOHS 401, and I'm an instructor for IPHS 401. So I've got a number of different things, but if anybody wants to reach me, I will be in my office from 2 to 3 on Wednesdays and happy to meet with folks. I apologize, today is probably an exception. I might not I won't be there from 2 to 3 today, but in the future I will be. You can always email me by Zoom if you want an appointment. I define myself as an environmental and occupational epidemiologist. And so I'll go through my research a little bit, but I really am interested in using a cumulative impacts framework to identify factors influencing susceptibility and vulnerability in populations. And my current research is working on how residential disadvantage intersects with environmental and chemical pollutants and influences accelerated biological aging. So I'll talk a little bit about that today. Outside of work, I really enjoy spending time with my family. I have 2 daughters and a husband. And I moved to Chicago in August 2022. And when I'm in the city, I really enjoy long runs and walks along the lakeshore with my dog. This is one of my 2 dogs. Her name is Brandy. So that's who I am. Hope you guys are all, it's about it. I mean, I can tell you more, but it's not that exciting. So how did I get to be the division director in EOHS? When I was in college, I went to school in New York City in an urban campus like this. NYU back in the day was very, very much like UIC. Over 50% of the students as undergrads at NYU were commuters. It was in an urban setting. It was incredibly diverse. And it's one of the reasons why I like UIC, because it's not New York City, which to me is huge. But it's a really great livable city. But when I was there, I was working actually on children's welfare and metropolitan studies. I wasn't working in public health. I didn't know that public health was a thing, but I got really passionate about things that you can see in this map, which show that in the upper, for people not familiar with Manhattan, this is the South Bronx. This strip of and community on either side, this white here is Central Park, and on either side of it are the super wealthy neighborhoods and communities of the Upper East and Upper West side of Manhattan. This map shows that asthma rates in this upper Manhattan area are 8 to 10 times the national average, whereas just to the south, they're well below the national average. And as an individual, I was fascinated with this question of trying to think about why this happens. Why do we what's the difference between these communities? And I did, and I was working with a community-based organization out of the city Department of Health as part of my undergraduate work. And we did some community meetings, and it really struck me that it's not just one thing. There's housing, there's job security, there's trucking. All of the trucking goes out of Manhattan right through here. The housing stock are huge high rises without a lot of regulation. And this area in the upper in the South Bronx is zoned for industry. It's not zoned for housing. So which means it's got housing next to factories, and it's got one hospital serving 15,000 people. If people are familiar with New York City, over here in the Upper East Side, there's at least 2 hospitals. And it's mostly residential. It's a lot of concentrated residential, but it's mostly residential. You don't see a lot of factories. And there is a highway on the side, but it's not a highway plus a factory plus spaces and places that weren't meant for people living in them. So, and so this also is reflected in people's perceptions of their communities. In the South Bronx, over between 47 and 50% of the residents in those communities rate their housing conditions as fair or poor. And then they also have children who suffer at exponential rates from asthma and other things. So this is what spurred my career in environmental and occupational health, and what makes me really excited to be here at UIC. I did graduate school in epidemiology and health policy, and there was this guy here. I actually went to Baltimore thinking I was going to be a nursing student because I didn't know there was a thing called public health. So I went there and I started working for this guy, and he grew up in New Jersey. And he was really also very interested in this issue of cumulative risks. And before there was such a thing called cumulative risks, he went on to be the secretary for the Office of Research and Development at EPA after working with us. And he was always very involved with bridging academics. And before he came to Hopkins, he was the state health officer for environmental and occupational health in the state of New Jersey. And so, and he was very involved in environmental risk assessment. So that's where my training in environmental health started. I was working as an assistant. I was taking his phone calls. I was doing his meetings. I was watching what he was doing. And he said, I don't think you want to be a nurse. I think you want to be a researcher. And I didn't know any better. And I said, oh, okay. So here I am. But, and we worked on this project called the Pew Environmental Health Commission. Does anybody know about National Environmental Public Health Tracking? Some have heard about it. Okay. Basically, we were saying, like, in the 1970s, there was these agencies that were doing environmental health. There were agencies that were established for occupational health and safety, but we had health departments over here. And what happened is by the end of the 20th century, because this is when I was working on it, so in 2000, we really had this environmental health gap. We weren't able to link the health and the environmental data together really well, and people weren't thinking holistically about how do we bring environment and occupational health data together to really show. And we had a conversation today. These are still challenges for us as environmental and occupational health practitioners, is really showing the impact of some of our environmental and occupational health safety prevention work and the impact it's having on human health. We know it's better, but are we really measuring that impact and impact well? So this was a part, I got involved with that. When I left grad school, there was no way I was ever going to be an academic again. So I started as a Council for State and Territorial Epidemiologist Fellow at the Wisconsin State Health Department. I talked about this a little bit in the orientation, but really it was a great opportunity for me to figure out if public health at the state and local health department was something I wanted to do. As a fellow, I got to meet people from all over the country who were also working on indicator development for environmental and occupational health. I got to meet amazing colleagues at the state health department, and I enjoyed that job enough that I stayed there for a few years working as an epidemiologist. So this fellowship led to my first job as an epidemiologist, and that led to, I was in Madison, Wisconsin, and the state health department is right next to the university. So there's a lot of cross collaboration. So if it's kind of similar to here in Illinois, there's collaboration with Cook County, City, Illinois Department of Public Health, but it really led me to having an academic trajectory, which is kind of boring. I'm not going to get into it, but my passion is really thinking about environmental and occupational health broadly and thinking about the science of environmental and occupational health, and to make sure that we have sort of an interdisciplinary approach to the work that we do and think about what we as environmental and occupational health specialists can bring to the table. And it's really that expertise in linking these environmental hazards and exposures to population and occupational health. Why do we care? Basically, we know that over a quarter of the world's disease is related to environmental or occupational health exposures. And we know that this is is not equally distributed. And we also know that many of the priority environmental health, and I could put occupational health conditions, are things that are somewhat related to the environment. So the environment might not cause the disease, but we certainly know that it makes you more vulnerable to environmental risk factors if you have cardiovascular disease or asthma or even cancer. Increasingly we're seeing environmental exposures can exacerbate cancer over time. And pollution, total pollution compared to other risk factors. This is from a Lancet article. And this is pollution in the workplace, and this is pollution out in communities, is the leading cause of global deaths, much higher than, and this data is from 2017, so after COVID, this may have shifted, but much more than wars, malnutrition, alcohol use. It's this total pollution problem. So we have a significant place and space in the world of public health. The other thing that drives me is that there are extreme disparities in life expectancy, and these vary by place across the United States. And we have a role to play as environmental and occupational health specialists in addressing these disparities. This is a map of the United States where you can see hotspots where we have life expectancy across 10 years. And this is at the county level. I guarantee these maps are very similar and spotted very similar when you drill down to Chicago, Cook County, Illinois. We have huge disparities here as well. We just don't see them on the map because these are sort of aggregated at the county level. And the other thing that I think about a lot in the work that I do is life course of people and places. So a lot of the work that I do is in collaboration with other colleagues in sociology and demography who really think broadly about community and life course perspectives. So how neighborhoods impact inequity via a number of different ways. The one that sociologists like to talk about is weathering. So, and they talk about environmental conditions. And when they say that, they really, really focus on the disadvantage component of it. They don't think about the chemical pollutant. So we have places and spaces to contribute. They also don't necessarily think about occupational health and how that contributes to this weathering. But they really say environmental conditions broadly, and accumulated stress and lack of resources render individuals and subpopulations vulnerable to disease and mortality. And I think we have a place and a space to work combined with sociologists to say, actually, we also have to be working at these really important factors that often get overlooked in the regular world. And so I think we need systems thinking approaches to environmental health. When I started training, we just looked at the chemical environment and we just looked at how it affected exposure and well-being, and we only looked at one chemical at a time. But we know so many different things influence this. And so we need broader approaches, we need more interdisciplinary approaches, and we need more collaboration. And the work that I do really looks at this, how does this play out across the life course, as I said. I'll try to hide this. I can hide this, right? Hide floating meeting controls. There we go. When we look at the dose and intensity of stressors, we know that some people age normally and some of them have detrimental effects that happen much faster in the population. So we would like for everyone to have sort of this successful longevity and aging over time, right? But that we know that there are some people who are, and this is normal. I just spent 2.5 weeks with my aging parents. They're doing great, but they're changing. And it's not, I don't think it's harmful, right? But there are others who by 50 are having the same trajectory as my parents who are now in their 70s. And so these are one of the things that I've been doing as part of my research in this context is trying to think, what are the biological mechanisms by which we can start to think about this weathering hypothesis, linking environmental and social factors together. And one of them is thinking about the biological mechanisms of stress and the systems that get influenced by stress from mental health challenges. But all of these systems also, with the exception of our targets for environmental chemicals and pollutants. So this is the stress mechanism. So if you're under psychosocial stress, your HPA axis gets on hyperdrive, and it affects your endocrine system, your nervous system, your immune system, which leads to inflammation, oxidative stress, DNA damage, cell death. And then it can lead to these different variabilities and susceptibility to chemical exposures. This is just a cumulative impacts framework. I'm just going to go through that fast. But these are the same biomarkers that are underlying cancer, but these are also the same biomarkers that are underlying a number of chronic conditions like respiratory outcomes, cardiovascular disease. And they're all also influenced by environmental exposures. So we took this biological clock. One of the mechanisms that we looked at most closely is DNA methylation. And I'll get to that in just a minute. And we're using that DNA methylation to look at biological clocks of accelerated biological aging. And biological clocks are measuring accelerated biological aging versus this DNA methylation. And we're using data from a cohort in Wisconsin. And we have data on chemical exposures, social factors, and neighborhood built environment factors. And we have gathered a lot of that data via questionnaire, but we also have collected blood data and analyzed whole blood DNA methylation on over 1,500 people. And we have longitudinal data on about 500 of those individuals. And so now we're doing these markers of accelerated aging. This is sort of the data that we have. We have contextual data, we have household level data, and we have individual level data. And we are looking at these different markers of DNA methylation on top of the DNA. So our DNA doesn't change over our life course. What changes is how the DNA and genes are expressed over time. So why does my nose is different than my thumbnail? It's just different than my eyeball, which is different than my liver. And it's because all of our cells in our body have the same DNA, but what gets expressed to say, become an eyeball, become a liver, become a this in our cells is driven in part by this DNA methylation process. It's one of the epigenetic processes that happen. And they call it DNA methylation because there's marks that happen across the entire genome that tell genes when to be expressed and when they dampen the expression. So that's a really, for those of you who are molecular biologists, that's a very crude way of explaining it, but essentially that's what it is. So DNA methylation is a way to alter gene expression. What we can do when we have methylation data on DNA is we can then use a number of those different marks. Statisticians have designed markers of accelerated biological aging, and I can go into this in another lecture more deeply, but to say, do we have biological aging that is different than what our chronological age says? So based on these DNA methylation marks, does it look like we're accelerating faster? Is our longevity decreasing, or are we having protective effects in the population? There's a number of different clocks that are out there. There are a number, and they're all, and the original clocks, so this is your chronological age. Originally, the statisticians designed these clocks on DNA methylation to be highly correlated with our chronological age. So they were very, very close. Increasingly, there's clocks like pheno-age that take into account a number of different factors, which can contribute to understanding accelerated aging a little bit more in the population. So our study population, this is the chronological age of our study population. This is this Horvath clock that was designed to be pretty highly correlated, and it is. For those, an R square of 0.95 means super high correlation. And then this other clock is called pheno-age, and it's slightly less correlated. And overall, our population has an accelerated biological aging that's slightly younger. And this is a population of Wisconsin residents. Most of them are fairly high resourced and fairly wealthy, and a lot of them are between the ages of 40 and 50. So one would argue that this is it. So we looked at different measures of biological aging to see if things were higher or lower in the population. And what we found is that your racial identity, people who had, this is really small numbers, so I'm not even going to look at race because it doesn't even mean anything in this population, because we have more data. This is just the generic data. This isn't the publications that are coming out quickly. But what we can see when we took our initial screen is that people who were class 2 or 3 obese had aging 3 times. We're aging 3 years faster than people who had a normal BMI. We also found that people who said that they were current smokers were also aging 2 years faster at a 2-year faster rate. And then people who are expressing stress from meeting basic needs, and they were saying that as greater than moderate, had about an accelerated 1-year age. But it's amongst those who are saying, I have neighborhood stress, that had accelerated biological aging that was very much equivalent to obesity, and it was very much equivalent to smoking status. And one might say, well, all these things are super highly correlated. How are you going to know that that's really the thing? So before I get to answering that question, one thing we did was we looked at lead and fine particulate matter, and we didn't see a lot of accelerated biological aging by different quantiles in the population. But we did want to look a little bit further at this result related to neighborhood stress. So we ran what was called linear regression models, and we adjusted for age and gender, body mass index, education, and individual income, and some important biological factors. And we saw that we continued to have increases in accelerated biological aging for neighborhood stress using these adjusted models that were equivalent to smoking. And we didn't really see anything with lead or PM 2.5. So even when we adjusted for all of those different collinear things. And our future work is really looking at residential disadvantage. So we've done lots of different maps to look at how movement across disadvantage is accelerating this. And then we're also adding in more environmental factors. So that's just my research. So I'll pause for a second. Do people have questions? That's what I like to do. Okay, because I'm going to totally switch gears now.
Can I ask a question?
Yeah, please.
Yeah. So we are really fascinating. I was wondering, could you speak more about how you measure the neighborhood stress?
Yeah. So we measure neighborhood stress in 2 different ways. One, right, people love to use data that's available, right? So we have maps, and we have maps of disadvantaged, and we have 6 different indicators for neighborhood stress right now that the sociologists love, which are percent of renter household, thinking about household instability, aggregate neighborhood level income, neighborhood level aggregation, and other things. And lots of people around the world are using that as measures of disadvantage. So it's kind of the same 6 indicators. Bye. It's okay. No problem. You guys can leave at any point. That's great. So I can get you exactly what indicators we have right now, but we're building those neighborhood stress indicators. What's interesting to me is that we also have survey data where we actually ask real people, what are your experiences in your neighborhood? Because the question is, is it really an exposure at the neighborhood level, or is it the stress from living in this neighborhood? And we don't really know the answer. It's probably a combination of both. But the neighborhood stress measure that we had used in this is, it's pretty much, it was a stress scale, and it was pretty much an item that said, how much stress do you feel from your neighborhood? And it asked about stress from a lot of different things like job and other things, but how much stress are you feeling within your neighborhood? And it was a Likert scale. So people will learn this, but it was a scale of 1 to 5. And then we did sort of a cut point. And it's interesting. There's a lot of suburban high income people who say they're stressed about lots of different things. So it doesn't just go along socioeconomic status lines, but a lot of it does. Yeah, Ed.
Do you weigh the neighborhood stressor information? Is there like more value to the Likert interviews as opposed to like rental information?
We've analyzed them separately. We haven't quite combined them yet. But the data you just saw was based only on the questionnaire data, not on the aggregate data. But we have address level data for all of these people, so we can also look at that. Yeah.
Oh, with the box with like the 3 different age metrics.
Yeah.
So for the second 2, their outliers kind of went pretty low. I guess how would those be interpreted? Like, I guess how would those be interpreted?
What do you do with the outliers? You're such a good methodologist. These ones here?
Your last semester.
Okay, let me ask others in the room who are methodologists. Do you feel like these are outliers that go really far? Are these the ones you're talking about?
So I would say no, but there's one that's negative, which I personally have not problem with, but it can't be less than negative.
You can have a negative correlation.
But is that not saying that's?
Oh, you mean like a negative age? Yeah.
So I agree, they're not like standard deviation or whatever, however you like to tell outliers, but being less than 0, I have a problem with that.
So this is how it came out in the pheno age. So what, this is just the original descriptive data. So we do have a lot of quality assurance and quality control to go back and clean those numbers up. What would you do with them? If you didn't trust them, what would you do with them? How would you handle it?
Can you remind us of what pheno age was? I forgot.
Yeah, so it's a marker of 350 CPG sites that are used in this elastic net regression algorithm that are combined, and the proportion of methylation across those sites give you an overall score of your phenological age. And this is looking at your total age as predicted by the clocks, which means that if you have an age less than 0, it means that your age didn't get calculated exactly right. So there's a couple different things we should be doing. You go back and clean it up, or yeah. So I think it's less complicated than that. I think it's this is a screening box and whisker plot, and we have some QA/QC to do to see if it's actually real from a pheno age. And if it is, then there's probably something wrong with that blood sample. And probably what we should be doing is dumping it. So But you can have an age less than 0, I think, with this pheno age clock, because it's based on a cluster of DNA methylation markers mapped onto an algorithm for chronological age. And it could just be the pattern of DNA what we would need to find out is is this real? Like, does the pattern of their DNA methylation suggest that they're less than 0, in which case they don't have an age, or is it not? Does that answer your question? Those are good questions. Other things? I like the questions. They're all good. Okay. So who are we in so I'm going to shift gears again. Any other questions? Okay. I'd rather have answer research questions than stand up here and talk, but I just want to make sure that we are all here and on the same page. So in environmental and occupational health, we're community focused and student centered, and we value environmental justice, health equity, inclusion and diversity, and healthy and safe working and living environments. And we strive for excellence, innovation, collaboration, and integrity in our teaching, research, and service. So we were in a meeting yesterday saying, do we have a value and mission statement? And in fact, we do. And we're complex and we're big. So I thought this is a good reminder for all of us. This light blue is something that we're working on actively building right now, which is a Center for Climate and Health Equity. We have a number of occupational health and safety centers here in the division, and many of the leaders are here in the room, and I'm going to go through them and hopefully people will raise their hands. And then we also have a lot of environmental science that happens. We have a lot of exposure science, water quality and management, air quality, aerosol science, environmental epidemiology, and data science. So we all have, this is the breadth of expertise that's here. And if you're interested in any of these things, please let us know and we will connect you with the right people who know how to do these things. Let's see. Summer in the city. This is just a few examples of some of the things we do. I just think this is fun. We go out and we monitor and we do really important public health. So this is the beach monitoring program. Anybody in here do samples over the summer? Sam did. Sam ran it all. Oh, you did it too? There's 3 of you in here? Okay. So you guys were out there. I don't know. I think it's very cool that we do it. Maybe you don't think it's fun though. Was it fun?
Oh, I don't do speech sampling. I'm in the lab.
Oh, you're in the lab. Oh, so you 2 work in the lab. Okay.
Yeah.
So all of you were in the lab. So you weren't actually doing the samples. Okay. Well, I have pictures of somebody out doing the samples too, but it's a big program that we have here in the division, and it's something that we're proud of in the Chicago Department of Public Health. And we really help, our neighbors in making sure their beaches are safe to drink from. And Abhilasha and Sam, Abhilasha's online. She's here, but she's really busy because you guys are wrapping up your work and she's trying to get it all cranked out. So we also have, this is really a ton of Dr. Erdahl, who's also in our division, does a lot with air pollution exposure and health risks. We have a number of other climate and health and air pollution folks. So we have Hong Yuk's in the room. Mehdi's not in the room. He's a air scientist. Dr. Erdahl's not in the room. Yuan, do you call yourself an industrial hygienist or an air pollution exposure scientist? Industrial hygienist. Okay. So anyways, air quality is something that we focus on in the division quite a bit, and there's a number of faculty who do that. We have this exciting NIOSH Ag Center, Dr. Force, who's not here or in the room. I don't see any of the Ag Center folks here today. Oh yeah, we do have folks from the Ag Center here. Okay. So we got Ag Center folks here, but really this is thinking about in Illinois, we have 35,000 to 55,000 farm workers who migrate or shift into ag work. And so this center is really focused on understanding the public health impacts of farm workers in our state, and I think pretty much beyond as well, right? So Elena is a program coordinator, outreach, communication, and engagement, and Tessa looks at psychosocial effects amongst farm workers. So we do a breadth of research. Anything else I should say about the Ag Center? Okay, cool. Then we have the NIOSH ERC, which many people in this room are, and many of you as students are involved with. Currently that is being led by Dr. Susan Buchanan, who's up here in the front. It's a training center, so we think about industrial hygiene training. If you're an industrial hygiene trainer as a faculty member, we got you want to raise your hand. We've got a team of trainers here. In terms of education, Margaret is industrial hygiene. Tessa is in charge of OC safety. We also have continuing education and outreach. Vidisha is part of all of that. And Dr. Pratap, who is not here, I think she's traveling, right? Globally? Yeah, she's in India today. Oh, and Ahmed. Okay, where are the Ahmed folks? So we have occupational medicine. Thank you.
Peter.
Hey, Peter. And others. Okay. Great. Thank you. All right.
And thanks for everything for the food.
Oh, thank you. Thank you for sponsoring the community cafe and the food. We're really happy to have that here. Okay. Then we have the UIC Center for Healthy Work, which is Kristen and her whole team of folks. There's a whole team. Really, it's focused. It's really a center that's focused on total worker health and precarious workers. So a lot of this cumulative impact work is analogous to a total worker health framework. And so that's really how they address things. There are a lot of really great community partnerships and work that comes out of that center as well. This is a dark picture. There's the minor center. A lot of people are researchers within the minor center. I don't know that any of Kirsten's also a PI on that one, but that is really focused on Black lung disease and lung cancer. Do you also do lung cancer? Yeah. Do you do lung cancer in the minor center?
A little bit, yeah, we do.
Okay. Okay.
It's mostly other, non-malignant respiratory diseases, but we do.
Okay. And that center does a lot of work both here in the United States. And there's Ahmed docs who have clinics here in Chicago, but we also have, it's my understanding, partnerships in Australia where mining is still ongoing and pretty significant. And so there's a lot of great things that happen as part of the minor center here as well. Susan, you want to talk about your PACE-U?
Sure,
Okay.
I'll put my phone down.
Okay, cool.
So we also have a small center on children's and reproductive environmental health that's funded by EPA and CDC/ACSDR. And we are not funded for research, but it's more outreach to other healthcare providers to teach them about children's environmental health issues like lead. We're doing PFAS work. So outreach to healthcare providers and communities. So we've got really active over in Benton Harbor, Michigan, on some of their lead and air quality and asthma issues, and we're going to approach PFAS issues. So there are some opportunities for students if you're interested in like going over to Benton Harbor for a health fair and talk about air quality index and asthma. So just let me know if you're interested.
Yeah, thank you. Yep, and I don't want to forget, we do have a very strong occupational medicine and residency program that's been ongoing here for a really long time. And we have some of our, we have a lot of folks who are really involved and engaged in that. And then every year we have at least 2 trainees in that program who are here getting their MPH along with all of you as trainees. So Peter, you want to say anything about that? As a former director? Okay. So future directions, I think, we're trying to build this Center for Climate and Health, but I think we're also trying to make sure that we integrate environmental and occupational health because we're really all trying to do the same thing, which is protecting people from their environments, whether it's in a workplace or out in the community. And so we're focusing more on education, research, and practice with a lot of these different themes that are ongoing. One area of research that we have is global health research. I didn't really talk about that much, but Dr. Sam Dorovich and Mehdi and others have been traveling to Kenya to do some ongoing work there. And we have some strong community partnerships and collaborations. And then I know the global health program is here at UIC is growing, and there's other opportunities to potentially do environmental and occupational health work in other places in partnership with UIC and the Center and the Global Health Program.
I would want to say something about that.
Okay, great. Go for it.
Constantly troubling for students that are interested in doing environmental health policy on a global level. And nobody believes me, but you could be active and involved now in a variety of the things that are going on. one of which is a treaty around approach to all chemicals, how does that get put together, how do you control the chemical industry? Plastics treaty is the newest thing coming up there. There's some still activities around mercury. Those that can work on. You can become involved in writing policy, negotiating, find somebody, go to the meetings, etc. So anybody interested in that whole area, love to that, and you don't have to wait until you're detailed by CDC every 20 years. Go into action and do stuff right now. And as a corollary of that, it's also a memorandum of understanding with the human public health school. And for the last 3 years, there's been students that have gone to Cuba, particular overseas spring. That takes about 2.5 weeks to send it. And you can be involved with that. So if you're interested in all of that, Alice is coming out. He's in charge of that whole area.
Okay, so this is Dr. Peter Orris. He's the former director of our OCMED program here in the division, but also continues to be actively engaged in lots of different activities here. And you think contacting Allison Lofthouse would be the right way to go? Okay. Great. Okay, I'm done. So I think when I said earlier, talk to somebody you don't know, your charge for the next 15 minutes is to talk to another person you don't know and say hello. And I really want to welcome you all here.